Hi everyone, my name is Omar Mustafa. I'm a consultant in diabetes. I work at King's College Hospital, and up until COVID for the last 5 years, I used to do my community clinics in Croydon, in various locations in Croydon, hence my connection to Croydon. And today I'm been asked to talk about diabetes. So I prepared something along those lines of kind of introducing what diabetes is, what pre-diabetes is, and some of the concepts behind that, and also some helpful tools to help people with diabetes consult with healthcare professionals. And then I'm happy to take questions afterwards. So when you talk about diabetes, the word diabetes, some of these words may pop into your head or you've heard about it. But really, I've adapted this from what the diabetes specialists in children use, and called the 4Ts, and that is going to the toilet a lot, being thirsty, tired, and getting thinner. And if you want to put a definition to that, it's a condition where you're unable to use your energy sources in very simplistic terms. There are lots of types, and I'll go through some of those. And that sort of imbalance leads to the symptoms that you see here. Which could be a presenting symptoms, but also could be when things are not going in the right direction. So this is not necessarily what happens when someone's experiencing the condition. It is a multi-system condition affecting multiple parts of the body. Holistic, and you can see the number of organs, including teeth, which until recently I was asked to talk about that, and I found a lot about it in the literature. And some of the aspects that people with diabetes and us as healthcare professionals may see, whether you are doing diabetes as a specialty or you're doing general medicine or emergency medicine, may come across. And that tends to happen slowly, sometimes all of a sudden, and sometimes some of these can actually be the presenting feature of diabetes, particularly heart attacks, strokes, and also foot complications. How do we know someone has diabetes? Obviously, we listen to the person telling us what was going on, but as doctors we have tests, and therefore we look at this. And if we look here at the top figure, this is when you have a simple blood test to check what the blood sugar is. You get a number, and then we plot it onto that figure. And this is when in a fasting state. Traditionally, if we want to challenge the body to see what happens to that blood test, we give somebody a high load of sugar. This is equivalent to a big glass of Lucozade or equivalent. And then you get another value to put on the figure. The two figures, the 2 points here will give you what the condition is. The reason I put it through a spectrum is it is a spectrum of conditions, and the borders of where things is called diabetes or not is really based on big data sets, big epidemiological studies of what that means. And a figure was drawn based on where things started to go wrong. And that brings me to, we know where things are when someone has diabetes. We know when this is not diabetes. And there is some spectrum in between of, it previously used to be called impaired glucose tolerance and post-fasting glucose. But really, it's an emerging concept called pre-diabetes. It's when somebody has the potential, or there's a problem happening to develop diabetes, and this goes to the right. The criteria obviously change, blood tests change, and now you may have seen that we do, or your GP may have talked about a figure called HbA1c, or sometimes in short A1c, and that gives you a figure in percentage or another figure out of maybe 48, 58, 68, etc., and it goes up to 100 plus. And that's what most commonly used there. So we use the HbA1c and a fasting glucose, and then we look at it and make a decision of where are you on that spectrum. Now that to diagnose and to know when someone has a new problem, maybe diabetes or pre-diabetes, but this figure here, the percentage figure from HbA1c, can also be used to monitor how treatment is going. And whether the therapies are being effective or the certain conditions in the body are favorable so that you have better long-term outcomes. And what does that mean? I'll bring an engine analogy. So if you view your body as an engine in charge of maintaining a status that is favorable to the body, allows the person to lead a good life, a normal life, a good quality of life, then you'd expect to have a good design, a good maintenance structure, fuel goes in, you get performance and output. In medical terms, the genetics is the design, which is so far non-modifiable, but in 50 years' time, someone else might be talking about something completely different. But what we can change, what can be done about, is what goes into that machine, how you maintain it, how you look after it, and what comes out of. And that's what I'm going to go through for the next few slides about how to look for things. So, and before I go through that, there are different types of diabetes. But broadly speaking, the modern terminology focuses on type 1 diabetes and type 2 diabetes. So if I start with type 2 diabetes, it used to be called an older person diabetes, diabetes that happens because you haven't done this or you haven't followed this diet or this way of lifestyle. Our understanding is getting better and better. And it's effectively, if we go back to what I've talked about in terms of, there's always interactions from the genetics, but also what happens here, of how you eat and drink, how you lead your life, what are the stresses in your life, what's going on, are you sleeping well, etc., which tends to push things towards higher sugars, higher glucose values. And type 2 diabetes is the most common type in the world. In the UK, it's also the most common type of diabetes, and it has higher prevalence in non-white populations. So we see it, I used to see it very commonly when I used to do the clinic in Croydon, and also when I do my clinics at King's. It's very different to type 1 diabetes, which is triggered by an immune, an array of problems in the immune system, whereby the immune system starts to attack the pancreas, where insulin and regulation of glucose happens. And therefore, you end up with a phase of problems ending with almost near complete inability to produce insulin, and therefore presenting with problems. It's a very distinct type of diabetes from type 2 diabetes, and it can only be managed by insulin so far. But that's what we know. Type 2 diabetes, on the contrast, can be managed by tablets, also insulin, and also newer forms of injections. So there's more options here. How common? Well, depends where you look and how you look. Globally, again, it's type 2 diabetes. This is a global picture of diabetes around the world as of 2019. The bluer the color, the less, the more orange going to red, it tends to be higher. And as you can see in certain parts of the world, obviously some of the smaller islands, you can't see it very well, but it is becoming more common. If you see that map 50 years ago, this map was probably light orange, mostly blue. When you adjust that for age, and if you look at the same map but adjusting it for age, what you see is that certain countries and certain areas around the world are mostly affected, which gives you the indication that those sort of countries have a younger population, and that's what we're seeing. We're seeing a lot more people being diagnosed with diabetes younger. But that's also not only necessarily a change in the natural history of the condition, but also our ability to diagnose things earlier and our tests and ability to find these issues much earlier compared to before. In Croydon, this is data from 2018 of what the GPs record. Croydon sits, so the Croydon is the purple, the grey is England, and the red is London. And Croydon sits slightly higher than the England average, and certainly higher than London. If we look at it compared to the boroughs, London boroughs, again, this is from the same source, Croydon sits at the top end, which is here in terms of percentage, compared to other boroughs in London, which are on your right. If you look at it on a map, Croydon is a single geographical entity, but from a conditions point of view, that depends where the population is. And also some of that dots, these dots are where your GP practices are in relation to the single parts of the borough. And as you can see, it's very common in northern parts of the borough compared to the southern parts of the borough. That may be related to a number of factors, including where populations are, how populations, there's a lot of factors, but this is a rough map for you. So which brings me to an important aspect of how you receive care. And so I'm briefly going to talk about the different aspects of diabetes, but through what Diabetes UK called the 15 care essentials. And it's a very useful checklist helping a person with diabetes consult with their healthcare professionals, but also serves as a way to know where they are and how things are. And it can be freely downloaded from the Diabetes UK website, which is the UK charity for diabetes. So the first thing obviously is to know where the sugars are. The chart plots the HbA1c, which is the figure I talked about of how high the sugars have been in the last 3 months or not, and the relative risk of issues or problems. Now, knowing where you sit in terms of your HbA1c will be crucial, and you'll hear doctors, nurses, healthcare professionals talking to you about HbA1c, going on about HbA1c. The relevance here is now it's maybe fine and it's okay, a little bit on the higher side here, but in a few years' time it may not be, and that's crucial to pick up and act on. Crucially, not only knowing an average for the last 3 months, but knowing where you are depending on what types of therapies, particularly if you're on insulin, if you're on injectables, would be crucial, and having the right means to test your blood sugar will be important here. Again, to know where things are and how you feel, because again, you may experience the 4 T's that I touched on earlier. Importantly to remember is that sometimes you get a lot of treatments added on and you go, what's going on? And suddenly you have one of those events of low blood sugar or hypoglycemia in medical terminology. And some of these symptoms you may have been experiencing, but you're not entirely clear. So it can be also, it can be serious, as in needing admission to hospital or an ambulance call or passing out, or simple things like feeling dizzy, heart beating too fast, or sweaty. So knowing where you are in terms of your levels would be crucial here. This is for type 2 diabetes and obviously for type 1 with insulin. There's no shortage of treatments. Here, this is a figure from, it's quite old now, from 2013, but the number of treatments continue to rise, and we will see more options of treatment. And I'm talking about type 2 diabetes particularly, but even for type 1, there are more options and immune therapies coming up. So watch that space. The second aspect is blood pressure. Ethnic group, that is very relevant. For example, in people of Caribbean or African heritage, there's a higher risk of stroke, as well as having high blood pressure having an impact on the kidneys and the eyes. And again, if you think about it like a filter and you put too much pressure through a filter, it can break. And breakages can appear in terms of how the kidneys function, which I'll come to, and also how the eyes and what damage can happen to the eyes, which will be important to monitor, which will come in the points after. People talk a lot about cholesterol, and again, thinking about what goes in, that's one aspect. And it's important to address, and I'll come to the diet in a second, but also how the engine is working can affect the cholesterol, and the importance of having the right medications for that and optimizing the glucose levels. The eyes, a lot of people have their eyes checked with their optician, which is great, but that does not replace going for retinal screening. Looking at the back of the eye is crucial for somebody with diabetes. Usually it's every year, but sometimes people may need to go more frequent, particularly if they're having treatments. And again, treatments are improving. They used to be just laser and improve the risk factors I talked about. But now there are more options, but crucially, it needs to be managed as a holistic condition. What often happens with retinal screening is that you get this letter saying everything is fine, thank you very much, but there's no explanation. And sometimes when you see healthcare professionals in the eye department, ask them what's going on, and they can write it for you or connect towards what's going on. Because for me as a diabetes specialist, I need to know what's going on, because that may influence how we manage things and how quickly we manage it, because it's very important. Feet and legs are very important. We walk on our feet, and therefore there's a lot more pressure on there. And as a result of a number of factors, the blood vessels and the nerve signals going to the brain can be affected, leading to a lot of problems. So again, having a regular check yourself, else can have a look for you, and with dietary and, if necessary, in hospital will be crucial here. Kidneys, I touched on about that, but basically we look at it by a blood test. A lot of places don't do a urine test, which is incredibly helpful to pick up the early signs of issues that can be potentially reversed, irrespective of the type of diabetes. So having an annual urine test is crucial, and if that doesn't happen, please ask for it. It helps a lot to stage where things are. Diet is a big thing. Food labelings can be as confusing to a number of people, including the specialists. So navigating the added sugars and terminology is important. And Diabetes UK have got a very good resources here. Looking at calories, carbs, portions, but also having a balanced diet is crucial. I find this very useful, using the hand as means of measuring your portions, all the way from a pound size to the thumb size. And as you can see it here, if you Google it, you'll find a lot more information on there. And knowing where you are in terms of your weight is crucial. Importantly, timing is important. A lot of people like to eat late at night, which is very bad for you. We're designed and we've evolved over time to sleep at night rather than eat, and therefore all our hormones tend to work to help us sleep. But if you eat in the middle of the night, you're giving your body an extra task. Now, sometimes the urge to eat is crucial and important, but it's often false. Craving rather than hunger. It's very different. Access to a dietetic service is crucial, and you can ask your GP to refer you to that and refer to resources. And I'll put some resources at the end for you to have a look. How you feel about things is always very crucial. We know, and we have evidence from studies and services like the 3DFD, which sadly no longer runs because of funding issues, that if we treat depression, if we manage access to other factors in social care, things improve. And just by looking at numbers, it's better, but also when you measure quality of life through analysis of the cases that have gone through that program, it did change a lot. So it's not about harping on about medications, diet, but also what's going on around you and how you talk about it. And also, there are a number of helplines. This is one of them, the Diabetes UK one, which is staffed by people who can help you to direct you to resources, and also you can talk to your GP or your other healthcare specialist. But crucially, we want to know if you come to a diabetes clinic, what's going on in your life. I often ask people, if I meet them for the first time, what do they do? How's life? How's things? And because then that puts things into context. We look at the person rather than the disease or the condition. Education is crucial. So there are structured education courses for type 1 diabetes, as is for type 2 diabetes. And the names, as you can see, Daphne for type 1 and Desmond for type 2 diabetes. The other thing is, it's often the case that you don't know who you're seeing, where they are, how to access them. This is the model of London diabetes, and which is replicable around the country. Certainly, most diabetes is managed in primary care, and actually there's another layer, which is layer 0, which is much bigger, which is self-care, which is incredibly important for people to know how to manage it themselves and seek help where required. So that goes from GP, enhanced GP services, specialist services, which may be in the community, like one of the clinics I used to do, and the top tier type very complex services that run in specialist centres, in hospitals like Croydon University Hospitals, or in other centres where it requires further input. That, for example, transition care, children's services, pregnancy, complex diabetes, pump technology, etc. The flu jab is important. I deliberately didn't put COVID in there, but for standard flu, it's still very important for people with diabetes to have their flu jab every year, because the bugs update their programs every year. So you need to get on top of that, and it's available free from your GP. In fact, most GP services call you for that. Good care in hospital is a big issue. Another side of my job plan is diabetes care in hospital, and there's a lot to talk about that. There's a whole discussion for another day, but knowing that you can self-manage, and if you can't, someone else will manage it safely for you, is crucial. So voicing where you are and what you have and how your condition is managed is important for sometimes wards or settings in hospitals that is managed by non-specialists, because we can't manage as diabetes specialists everywhere in hospital. This is a big topic, and it's important to talk about it, and it can be difficult to do, so you need to find the right moment, the right time, but it's important to talk about. And I'll leave you with one thought, that, for example, people who have problems, and particularly men, tend to have higher cardiovascular problems, higher rates of heart problems. But there are three elements to this. There is the heart, the blood vessels, there's the nerves, and also there is the psychology. So you don't know which is which until you talk about it, so that you can figure out, your healthcare professional, your GP or specialist can figure out which one of these three, is it your vessels, the nerves, or the psychology that is impacting on that, or just general life. Smoking is a big thing. It's the best thing you can do ever. We know the risks go up the more you smoke, but also the earlier you stop, the more years you buy of your life, and that's just a figure on your right for you to see. For women planning pregnancy or want to start a family, it's crucial to get this planned and established, because we know that high sugars or uncontrolled sugars result in big babies and big problems with delivery and complications during labor, and certainly during pregnancy. And the pregnancy clinic, we know they do a lot more. There's a lot more follow-up and encouragement to keep things as tight as possible. So plan it, and please talk to your healthcare professionals about it, to plan things in advance. But I come to the main point. We're all individuals, and yes, there are certain criteria that you can healthcare professionals can follow, but it's important to establish your individual circumstances and your individual needs in there, so that your healthcare professionals can work around it, rather than giving you something that doesn't work and you have to work around that. The diabetes have to work around you rather than you doing the other way around. Care planning should be, you should be in the middle of it rather than on the periphery somewhere, some people talking about you. So getting involved in care planning is crucial. And some myths. This is a chart that we did for inpatient care, just to take through things. So the first myth was there's insulin dependent is a type of diabetes. It's actually a dependent, or it's actually insulin treated. And as I said, there's type 1 and type 2 that can be managed by insulin, both of them. Intravenous insulins are particularly relevant for inpatient diabetes, can be disconnected, which is wrong. So if you see that, please tell someone it's not right unless there's a very good reason, because then this can cause problems. And if someone has a low blood sugar, that means they can't have their insulins. That must always be taken. The long acting, the short acting may need to be adjusted, which is particularly relevant for someone with type 1 diabetes or someone with long-standing type 2 diabetes. And I would say here a fourth column should be that if you're feeling unwell, all treatments should be stopped because you haven't eaten. Again, when someone is unwell, they need more insulin because the body is under huge stress. And we see that all the time in hospital. So again, insulin must be taken, and there are sick days rules that you can follow to get advice on how to do this. This is briefly some resources that you can follow depending on what social media you use and what websites you follow. You can use these. There's a lot more, but these are kind of your opening sites that you can follow. So my take-home message is know your diabetes, know your status, whether you have a pre-diabetes, keep it and others in check, and seek help early and talk about it. That's what I have. Thank you.
Thank you so much. Thank you so much, Doctor. Whew, okay, there was a lot. I've written down loads of notes, and I've got loads of questions as well, which is really good as well. But everyone, if you have any questions, please put into the chat, and I will be going through it. Doctor, can I ask you to unshare your screen now?
Yeah, sure.
And everyone still be kept on. I'm gonna speak of you. Excellent. Okay, so please remember, everyone, we are being recorded. So if you are asking a question and you do not want to be on YouTube, please put your camera on. Please turn off your camera. Okay, so let's just go through. Let me ask my question as well, sir. So of course, one of the reasons why we've done this session is regarding COVID and COVID-19 and the amount of deaths that's happened with people with diabetes as well. Is there anything more you can kind of tell us as well with what you've seen over the last 3.5 months with people with diabetes?
Yeah, sure. So with COVID, I spent all the time doing inpatient care, so we didn't have any clinics. So what the experience is twofold. The first aspect is it is an acute illness, and therefore people managing it, we need to be aware of how to manage it following the 6 days rules, and a lot has been done in that short period of time. The second is COVID specific. So in terms of COVID itself, we're still learning, and the evidence, I've never seen such a rapidly evolving situation with the evidence. The evidence seemed to suggest that the insulin requirements, for example, were much higher compared to other conditions we've managed, and that depends on what phase of the illness the person was in. It tended to be higher if they were really, really unwell and receiving particular forms of therapy, which were part of the treatment, or having new, very odd presentations, which we're still trying to understand. For example, people with diabetes coming in and suddenly deteriorating without even having warning signs. There were some warning signs, but the deterioration in their clinical conditions affected how they managed their diabetes, and therefore we had to take over in hospital. And there's a lot of other aspects about someone who is relatively well, and we found new diagnosis of diabetes compared to before, and we're still learning. So there's a lot of aspects, but what is similar to everyone else around in public is that the necessary to take precautions, and that is the same for anybody around. People with diabetes were classed as high risk, and that's the right thing to do to protect them with whatever evidence was available. And as evidence evolve and more data come in, that may change, but as far as we know, things are still the same.
Excellent, thank you so much. Everyone's asking for the slides, Doctor. I don't know if you
Yeah, sure, I will email them to you.
Okay, and let me just clarify, everyone, you will only get the slides if you complete the survey. I'm bribing you guys because I have 50 people on there and I get about 5 people do the survey. So if you want the slides, you have to put your email address in the chat. I will then send you the survey. Once you've done the survey, I will send you the slides. I'm sorry, I have to be tough on this one because so many people, but only very few. And the survey is only 1 minute, so please bear with us. Okay, some questions for you, sir. Can you develop diabetes by taking sugary things?
Well, I go back to my engine analogy. If you overstress that engine with bad fuel, you will develop diabetes sooner or later. Some people develop it sooner because of how their genetics are made up, and that's difficult to understand in some people. And some people won't have it as soon, but they may have it later. So having the right diet, the right amount, the right portion is crucial.
Excellent, thank you. Another question, can you advise on the best exercise for people with diabetes? My husband has found that lifting weights has had a positive impact on his blood sugar levels.
Well, we know that, I mean, it's difficult to know exactly which ones. Exercise in general, the evidence point out to better glucose, better blood pressure, better health, and better psychological health. So we know that in order to, even if you just walk slowly, it's better than sitting down. If you're standing up, it's better than sitting down. If you walk fast, it's better than walking slower. And there are broadly 2 different types of exercise. There is what we call aerobic, and there is the anaerobic exercises. And they both do well. In any form of exercise, you will, particularly aerobic exercise, you will burn the energy. The glucose goes into the cells without the need of insulin, whereas if you're resting, it will need help. So the better the exercise in terms of quantity, quality, and intensity, that tends to favor better blood sugars. A bit of warning here that if you're on a lot of therapies and you're intending to take a structured program or doing something, take some advice, because there's a lot about how to adjust those therapies, as there's a risk of having lower blood sugars after the exercise, which is a favorable thing, but that tends to be augmented and you can get into lower blood sugar territory where you need help. So, but I say any form of exercise is good.
Excellent. Okay, we've got 12 questions, so I'm going to maybe ask you to keep it a little bit shorter. We've got 12 questions, and I think they're popping up. Okay, we've got 13 questions. So here's another question, Doctor. I'm being told as a condition of my license that I have to consult a diabetic consultant in spite of objections of my GP. Question, how can I do this and how much does it cost, as it will have to be done privately? Is that so?
I'm assuming that's for a public carriage. Is that correct? It's not just a standard car, because if it's a standard car, class 1, that's relatively straightforward. Your GP or healthcare professional should be able to do that. The class 2, I think, is more complicated and requires a lot more rigorous intervention. You will need to consult the DVLA about that and ask them exactly what they need. And I'm aware that people wanting to drive buses and lorries will have to go through more rigorous checks.
Okay, thank you. Another question. Question regarding diabetes 2. Talked about tablets and injections, but no mention about using diet as an option. Also, can diabetes be reversed type 2?
Yes, very relevant. So diet is important. In the early stages of diabetes, there was a clinical trial about a year plus ago now, that works on that particular question. And they did find that a caloric cut, so cutting the calories to significantly lower amounts, tended to drop the blood sugars in people with diabetes, but also it reversed it, so what we call it into remission. And the people who did go into remission tended to be the people who had diabetes the shortest duration. And that's a crucial thing. So for example, if someone is on a lot of insulin, a lot of other injections, a lot of tablets, and they had their diabetes for 20 years, having the right diet is crucial, is good, but it is very unlikely to reverse diabetes, as opposed to somebody who's had diabetes for 1 year and their diet was full of high sugary drinks, very high refined carbohydrates, really rubbish diet, and they have more chance of going into remission. And the diabetes prevention program for people particularly who haven't developed diabetes, but they have the tendency to, does exactly the same. They go through exercise and diet program and psychological and coaching to get that result, to stop the progression of type 2 diabetes. And the data are coming out, and that was recently presented in one of the international conferences. So watch that space.
Excellent, thank you. We've still got 17 questions to go through, Doctor, so please bear with us. What oils, fats, and how much are best for diabetics? So what oils, fats, and how much are best for diabetics?
Well, as far as we know, with fat, if you're going to have that, it has to be combined with part of a balanced meal. If you're having an imbalanced meal, then that's when the problems happen. There are different types of fats. There is the bad fats and the good fats. And it's a very complex question when you read the studies, because the studies try to narrow it down to meals that are sort of ideal. And if you try and look at studies that did what people were eating, etc., it can be quite a messy analysis. But in general, fats, if you remember what I showed you in terms of the hand and the thumb, the fats tend to be thumb size rather than hand size. So the quantity is crucial because they are quite dense with calories and can clog up the arteries. But crucially, they need to be taken with a balanced meal in low amounts.
Excellent. Okay, thank you. This is a good question by Joe. What are the strategies in place for diabetics to return to work under the current situation? So we all know that you know, government's changing every single day. You know, I haven't turned on the news in the last 12 hours. So I don't know what anything else has changed. But there was a massive change yesterday. So with diabetics, is there anything change, or what's? So
the guidance from the government and what you can see from Public Health and Diabetes UK is that people with health conditions in general should go through a risk assessments. And where possible, their employers or where they work should be looking to see where their risks are and can they be mitigated, and are there any alternatives. So for people who are working with in organizations where there is occupational health, that's the occupational health, they need to go through that, and we've helped people pointing them in the right direction. So for example, if you go to the gov.uk website, you will find a risk assessment for employers and employees that you can read and try and understand. There are different scales and different ways of assessing it, and there is debate in the medical community of which one to use, but use one of them and just stick to the results and get your workplace safe for you to do your work. That's a crucial thing.
Yeah, I'm actually in the middle of doing my back to work plan as well, and I have to do risk assessments on all my staff next week as well. So that's going to be interesting conversations.
Yeah.
Okay, just going through the list. What is a good, sorry, I need to read this one. What is a good HbA1c for the start?
Yeah.
What is that? What's that word, sorry?
HbA1c, so a glycated hemoglobin. It gives you an average over the last 3 months. So that
for pregnancy. Yeah. Sorry, yeah.
So if you remember what I said about customize. The rough figure that most diabetes specialists work towards is 7% or 53 millimoles per mole. However, there are a number of factors that you have to take into account, and sometimes we set it very low. For example, 6.5 or less than 6.5 in somebody with early diabetes, no complications, and compared to somebody who's had diabetes for 30, 40 years, and there are about 3 or other comorbid conditions with the diabetes, and they have, for example, they're frail, and therefore having such tight glucose control can be negative to them. So therefore we tend to set it in a different way. So you need to ask your healthcare professionals what they are looking at rather than just what number is in the guideline. And the guidelines now are more clued up to this.
Okay, does that lead on to the same question, well, the next question is, what is the readings for normal blood sugar?
So diabetes in general, from an HbA1c point of view, below 42 millimoles per mole, that is not consistent with diabetes. That's before pre-diabetes. If you're looking at the just general blood glucose, anything, if you're doing a finger stick, that's anything below 6 millimoles per liter. That's not diabetes. But again, you have to know the context. Is it fasting? Is it 2 hours after a meal? 2 hours after a meal, if it's less than 7.8, there is no diabetes. After a good meal, main meal.
Excellent. Okay, thank you. Oh my word, you guys are keeping me busy. Not 20 questions or 20 stuff in the group chat. So please bear with us, Doctor. What are some of the common myths that you find in your work, BAME groups as well? So, and can I chuck in one there as well? Lucozade, does Lucozade help with diabetes, or the original Lucozade?
No, it gives you diabetes.
It gives you that. So somebody who has diabetes already, drinking Lucozade, because they say it raises their sugar, is that good or bad?
So Lucozade, we use it, or we used to use it, because the sugar content is halved because of the sugar tax.
Yeah.
We used to use it as means to treat people with low blood sugar, and that's the only context that you can use drinks with sugar added to them. Apart from the odd occasion where you fancy something and you're at a party or something, and having one every now and then is something that you can't avoid. But Lucozade is another sugar added, where sugar added is not a drink for normal days.
Okay. Okay, so let's just continue with that as well. Any other myths as well in the BME with the work you do, like that you hear other people saying?
I mean, I have a significant number of people. I don't know whether it's a myth or the evidence hasn't caught up. There's a lot, if you look online or if you go to the shops, they say, take this pill, take this herb, take this, that. We don't know. I mean, most of the drugs come from herbs and plants and chemicals. But you ought to be careful of when someone goes, this is really effective, because for a drug to get licensed, it has to go through rigorous checks, whereas those things are just sold straight into the market. Now, there is probably inherent expertise that people pass from generation to generation, saying, well, someone tried it, it must be good. If you look at it as a quality of evidence, that's few people compared to hundreds or thousands of people who are treated, who had been treated with the medication, improving their safety record and the side effects.
Excellent, thank you. Okay. Can we explore more? About good care in hospital? The food available in hospitals don't cater for diabetics.
Yes.
Wouldn't that contribute to the imbalance of care? Wow.
Yes, that's a huge issue, and that's a discussion for a whole.
It's a whole nother day.
I'll come and talk to you about it. The key thing in hospital is there's few things. There's food, and in some hospitals now they have food labeled with what it contains, particularly around carbohydrate content and added sugars, or there's anything that doesn't affect people with diabetes. There's also the expertise of the teams. For example, we spend a lot of time with non-specialist teams in hospital, upskilling, training, anticipating scenarios, and also as specialist care teams, we spend a lot of time managing people with complex needs. Just to give an example, King's is a 1,000-bedded hospital. At any point in time, we have about 20% of that people with diabetes. So we can't manage everyone, but we have a structured approach where we manage people who need us to manage and help them with the diabetes. But it's a system issue rather than a condition issue.
Okay, excellent. Thank you so much. Just battling through these questions. Hi, thank you, Dr. Omar, for a very informative presentation. Looking at your map in West African countries, is there any research taking place on the impact of consuming more of a Western diet versus traditional cuisine?
Well, very good question. There's a lot of interest in that, not only in West Africa, but across the world. There's an understanding now that Western diet tend to be more, it affects and it causes more metabolic problems. For example, there are certain additives. We know, for example, fructose, if added to diets, tend to cause more problems. Luckily, it's not used in this country, but if you import food from certain countries, you may find it in there. There is, back to the West African population, there is research. In fact, up the road from me at King's in the university, they're trying to answer the particular question about diabetes in West African populations and how that differs from people, for example, if they have Caribbean heritage or they have English or Middle Eastern or Oriental heritage, and how the diabetes can be different. So not only ways of life may be different, but also the internal fabrics and the internal, how the engine works may be different. So watch that space. The researchers keep coming. Just before COVID, we had a very good presentation from the team at King's College London on exactly that.
Okay, thank you. Okay, I'm going to ask for no more questions. We're up to 27 more questions, so no more questions, please. Let's battle through these. What does the reading mean, HbA1c-40 mmol mean?
Oh, so it's a unit. So for example, we measure weight by kilograms, we measure height by centimeter or inches. depending where you are. Millimoles per mole is a unit of measurement. The newer one for HbA1c, the older one is you just get a percentage. So it's just a unit, and it's important to mention the unit because you need to know what you're measuring and in what.
Okay, thank you. Is it recommended that nurse staff should have expertise in both types?
I assume that's general nursing. There is a certain level of generic competencies that all nurses need to have, and that is in administering medications, knowing how to measure blood sugar, how to manage low blood sugar, when to spot there is a problem. But there are more complex scenarios, for example, that a diabetes specialist nurse may need to intervene. So yes, for basic skills, the nursing staff should be aware of, and that forms a big part of our role as inpatient diabetes care teams in hospitals, to train up and keep knowledge up to date.
Excellent. Can we just go back to the Lucozade question as well? So interesting, quite a few people just said, you know, can Lucozade give you diabetes? Because some people take it when they're tired. You know, as I said, I say that and I'll raise the question because my mum has diabetes, and you know, she always asks me, can I buy her the six pack of Lucozade, and I'll go and drop it on her, you know, and she, oh yeah, it raises my blood sugar, it makes me feel, but you know. Is that
I think it's one of those urban myths that's the result of advertising, and that's true for all sugar-containing drinks. They want to sell, so it's not linked to specific brands, but it's something that you feel better. I mean, if you exercise, for example, and you have a drink, then yes, you will feel better. If you have a sugary drink, you'll feel buzzing. That's what the sugar is. It keeps you buzzing. But is it a good buzz? And I argue it's not, because there is no role for it. It's not part of a normal food that you see. It's not an apple. It's not a banana. Other fruits are available. But you need to put that in context. So I would say it's not the right thing to do.
Okay, thank you. I'm ringing my mum straight away. No worries. Thank you, Dr. Omar, BME, for organising this lovely information session. Okay, thank you. Yeah, thank you. Sorry, I thought that was a question. Oh, I think that's it. Oh, yeah, that's the last question. That's the last question. Okay, so we've still got Dr. Omar for another 2 or 3 minutes. So if there are any questions, please just drop them in quickly. Yeah, Doctor, I would say, what's the maybe 5 things? I think we've still got 30 people. We went up to 44, so we're down to 38 now. So what are maybe the 5 tips that you would maybe give somebody who has diabetes or trying to not have diabetes? Are there 5 tips that you can give us before we go?
I think for people who have diabetes, they need to know where they are and how their health is. And asking, I mean, quite a lot of people I see, particularly new ones, sometimes come to me and say, look, I don't know, I don't have access to this and I don't have access to that. And that's something to do with the system. So if someone just goes on about things, just ask them for information, ask them for, what does that mean to me, rather than just telling me what to do. And the second thing is, watch what's in food. There's a lot of hidden things. And particularly depending where you are, where you come from, what your heritage is, there might be other hidden things in food that you're not aware of. And portion size is key to watch. The people pre-diabetes, they need to be aware of whether they are prone to diabetes, so they need to do the risk assessment. So again, if you go to the Diabetes UK website, there's a nice calculator you can check and see what the risk is, and try and do something about it. It's very hard. You know, I haven't gone for exercise for more than a week, and it's not something that comes naturally to some people, but it's something important to do, and keep active and watch what you have, and ask for help. There's always someone at the end of somewhere to help you, whether online or in clinic or in a surgery.
Excellent. Okay, so we've got the last, no more questions. So we've got the last 4 questions quickly, Doctor. And I know, Juliana, I know you're on board. So I'm going. Oh, you've just sent a question as well. So I'm going to ask you to unmute yourself in a few minutes, Juliana, as well. I just want you just to tell everyone what other courses and workshops that we might be doing in partnership with you in the future. So let's just quickly. Oh, we must answer this one. This is from Kevin. I think he's asked it a couple of times, but I might have missed him. What is a good HbA1c to have before starting pregnancy?
So, in general, assuming there are the woman has no complications or other medical condition, usually my colleagues in pre-pregnancy clinic, they aim for less than 48 or less than 6.5%. It's quite tight, and that's the ideal. Sometimes they consider things and they may aim for less than 7 or less than 53 millimoles per mole, but it's very tight. And because we know that people who start with a good start and continue well throughout the pregnancy have outcomes that are very close and sometimes are equivalent to people without diabetes and they're pregnant. So
okay.
it's very important.
Okay, so these are 60-second questions, answers, Doctor. What is the meaning of long-term blood sugar?
That's the HbA1c. So it measures what it is in the last 3 months. So that's the HbA1c.
Okay. Can some medication make the condition worse?
Yes, so steroids in any form, so so prednisolone, dexamethasone, other injectable steroids affect the diabetes, and that's the most important one that we battle with a lot of the times. But it can be managed. If you need it for another reason, take it. Some antipsychotics, treatments for schizophrenia, affect the diabetes, and some HIV and the very old HIV medications tend to exacerbate the condition. We'll work around it. My message is have the condition treated, whatever it is, and if it affects your diabetes, we can work around that.
Okay. Do you do private consultations or?
I don't.
Okay.
Yeah.
Okay. How can people get hold of you or your department, or do they have to go to their local doctors?
So, well, yeah, generally, if you go to your local surgery and if you get a referral, I'm still at King's, so they can get a referral to me, or I'm happy to answer GP's questions if the referral is not, if it doesn't fit with the service criteria, I'm very happy to talk to your GP about that.
Okay, last 2 questions. When is the best time to eat fruits, before or after meals?
That's always a hot debate. I think if you regard it as part of, some people say eat small and often, not exceeding 5 a day, and some people have a smaller portion after meal and regard it as their pudding. So there is no hard end. Nobody has done a randomized controlled trial I'm aware of.
Excellent, thank you. And okay, so everybody's just been singing your praise as well, Doctor. Excellent talk from Dr. Mustafa. Thank you so much, Dr. Mustafa, etc., etc., etc. So